So we're back with the thyroid disorders today. So yesterday we have talked about the thyroiditis, the Hashimoto's granulomatous and Friedels and subacute. It's a lymphocytic thyroiditis. As you know that the uh, thyroid functioning is the basis of all these disorders. So you have to know how the thyroid functions, right? It is essential for the basal metabolic rate maintenance, and it is the prominent hormone that regulates the metabolism. Okay, and it is maintaining the hormonal and other hormonal and vitamin activities in the body. It is essential for temperature regulation. It is also, that's the reason why whenever we see a thyroid disorder, you also see certain conditions like slowing down of all the other metabolisms in the body. Okay, and we've seen that the hyperthyroidism can be primary or secondary. Mostly in the primary, it is Graves, where there is an it is an autoimmune condition. It is having a what do you call antibody to the TSH receptor. So there are many antibodies that can be present which can lead to the hyperthyroidism altering the normal functioning. Then there is this hypothyroidism. We have seen that there is primary, secondary and tertiary hypothyroidism, tertiary otherwise known as central hypothyroidism. As you know that the T3, T4 levels have to be maintained in the normal range. If the T3, T4 levels are high, it is hyperthyroidism. T3, T4 levels are low, it is hypothyroidism. So this hypothyroidism is again three types with intrinsic thyroid abnormality or a secondary cause or a tertiary cause or the central cause from the hypothalamus. As you know that the hypothalamus sends TRH to the anterior pituitary. The anterior pituitary sends the TSH to the thyroid. Then that's how it happens, right? So coming to thyroiditis, inflammation of the thyroid gland happens either by the autoimmune picture, something like Hashimoto's, where you will see numerous lymphocytes getting activated and then they will try to destroy the normal follicles. So what do you see here is the destroyed thyroid follicles by numerous lymphocytes. These lymphocytes form a prominent reactive follicle with a prominent germinal center. And also you see Hertel cells. This is the pathognomic of the Hashimoto's thyroiditis. Okay. In granulomatous thyroiditis, we see that there is some abnormality happening in spite of the thyroid initially, which can be maintained as normal. Then there can be overactivity, then there can be lesser activity. Whatever it is, the thyroid hormone levels come back to normal within 8 weeks. Okay, then Riedel's thyroiditis. Riedel's thyroiditis is a fibrosing thyroiditis where you can see extensive inflammation extending to the contiguous structures in the neck. It is stony hard, it mimics carcinoma, and very essential that we do a biopsy and or an FNAC to rule out carcinoma in Riedel's thyroiditis. I also talked about the lymphocytic thyroiditis, wherein there are no prominent Hertel cells or formation of the germinal centers or reactive follicles, but the destruction of the thyroid follicles is same as that of the Hashimoto's thyroiditis. Okay. In today's class, I'll be talking about the thyroid neoplasms, that is benign neoplasms, including the adenomas, follicular adenoma and the Hertel cell adenoma, and the other subtypes of both, and then carcinoma, the papillary carcinoma, follicular carcinoma, anaplastic and medullary. These are the four main types of the thyroid carcinomas, and we will also talk about the subtypes of the papillary carcinoma. So here, usually the thyroid neoplasms form a nodule. You know, we've also spoken yesterday about the non-neoplastic conditions wherein there can be a colloid cyst and then there can be a multinodular goiter, right? So as the term nodule has come, I would like to repeat about that too. Initially, the TSH will try to combat the low T3, T4 by sending signal to the thyroid gland to push itself to produce normal amount of thyroxine hormones. So when this doesn't happen, what happens is that it is causing a morphological change in the normal thyroid. So what happens? There is dilatation of the follicles with extensive cystic change, and the hormone that is the thyroid is present in the form of colloid. So this is a simple colloid goiter which is usually diffuse, involving both the lobes, okay, or diffuse in presentation as such. When there is this cycling of hyperplasia, hypertrophy, and then involution, and hyperplasia, hypertrophy, and involution happens like a cycle, then what happens? Then there is propensity for formation of multiple nodules because of the variable proliferative potentials of each thyroid cell. So I also give you an example that the thyroid cells are like students who may be doing well, not doing well, different proliferative capacity of each cell. So this can be a monoclonal nodule or a polyclonal nodule. So this is about the MNG. In MNG you see how is the morphology. You see multiple nodules grossly on the cut section. You see degenerative changes and multiple nodules, and these degenerative changes are cystic change, necrosis, hemorrhage, calcification, okay, all these things. So what do you see in the microscopy are a representation of these gross features, that is the cystic. There are these thyroid follicles arranged in the form of variably sized nodules, and these are having benign nature. They are not showing any pleomorphism, and these are accompanied by lymphocytes, cholesterol clefts, degenerative changes. I told you necrosis, calcification, hemorrhage, and fibrosis. That is the picture of MNG. The very important pathological term that is used to describe a multinodular goiter is the Sanderson's bolsters. That is where a conglomerate of the thyroid follicles appear at one end like that of the ring. Then there is a cystic change that is happening in the thyroid follicle. That is a dilated follicle. All the minute follicles in that conglomerate at one end. This is called as Sanderson's bolster. Okay. So, the thyroid neoplasm, unlike the, what do you call, a multinodular goiter, initially when it is benign or initially when it is involving just one lobe, it is having a solitary nodule. It is endemic in nature, more common in females, seen in increasing age. Okay. So early recognition for any thyroid neoplasm is an FNAC, that is fine needle aspiration cytology, where you just pick up a few cells from the syringe using the cytology and HLE stains and the GMSA stain. You will try to find out if there is an abnormality in the individual cell structure. So what are the silent features of these thyroid nodules? That most of them are adenomas that are benign, and then there can be sometimes neoplastic even in young males. History of radiation is important, and functioning nodules are usually hot. Then the good prognosis is that where there is less than 1% mortality pertaining to the thyroid functioning. Then what happens when there is malignancy is that there is infiltration to the other tissues. It can be fixed, that is hard, that is you can't move the structure. Hoarseness of voice is present. There can be recurrent laryngeal nerve damage which can cause change in the voice. So what are these neoplasms? Adenoma, follicular adenoma, papillary carcinoma, follicular carcinoma, medullary, and anaplastic, in which the majority is a papillary carcinoma. So coming to the adenoma, that is the benign counterpart of the thyroid carcinoma. Here you have mostly follicular, wherein there are compact follicles, that is small compact follicles. Then it is well encapsulated. It has compressed normal gland adjacent to it. So imagine you are seeing a thyroid gland like this. Then maybe you imagine an orange or something like a thyroid gland. You cut the orange. Then okay, I'll give you an example of onion. That would be better. Onion, if you cut, okay, what happens is that you cut the onion. Sometimes you find two onions, right? Two onions in the same thing. If there are some girls listening to this class. So there is a well circumscribed nodule as a neoplasm here. On one side it's normal. On the other lobe, there is one well circumscribed nodule. And the adjacent part is usually compressed because of this enlargement. Okay. So we can see that it is classified on the size of the follicle and the degree of the cellularity. So very simple colloid adenomas are normal. They sometimes resemble the follicular carcinoma, and it has to be differentiated from the follicular carcinoma because see, in follicular carcinoma you see that this nodule will have the cells pushing out or opening the door of the capsule and moving out. That is the pathognomic sign of the follicular carcinoma. That means there is a breach in the capsule. Okay. So what is the pathogenesis? There is alteration of the TSH receptors. Okay. And then this will have an guanine nucleotide binding proteins that will activate adenyl cyclase, and it turn activates the intracellular cyclic AMP. So this is activating a gene which controls the production of TSH and proliferation of thyroid epithelium. So there is a genetic activity going on which will go and activate the TSH that will activate the proliferation of the thyroid epithelium. So there is a mutation in the signaling system thereby. There is a chronic stimulation of cyclic AMP and then clonal expansion leading to a monoclonal thyroid adenoma. Clonality means there is one ancestor and from that all the progeny are coming, something like that, right? So mutations lead to increased activation of cyclic AMP causing thyroid. So what is the morphology? I told you, nodule is solitary, encapsulated, it is demarcated from the surrounding tissue. Okay, cut section usually compresses the surrounding tissue. Gray, white or red brown in color. There can be again the degenerative abnormalities like hemorrhage, fibrosis, calcification and cystic change. But this degenerative changes occur more with the time. So well-defined intact capsule is seen in follicular adenoma, whereas there is a breach in the capsule and you see these thyroid follicular cells which are compact moving out of the capsule is seen in follicular carcinoma. That's how you differentiate. So this is the follicular adenoma. You see that this is a solitary lesion. This is a cut section. You see that there is some hemorrhage, reddish in color. So you see this, that there is a prominent well demarcation from the surrounding tissue. So again another example, see here, there is a colloid here. You can see that this is a brownish tinge and this is a colloid separated clearly from the surrounding tissue. Another example, this is the follicular adenoma that you are seeing, which is solitary, well demarcated from the normal thyroid gland. See here, you can see the normal thyroid, you can differentiate it clearly. So this is another picture. Okay, so what are the types microscopically are that? Macrofollicular adenoma, wherein large follicles are there, the term itself says, and the microfollicular adenoma, where there are follicles separated by loose myxoid stroma, and there is compact, very compact cells with scanty connective tissue. Trabecular, closely packed cells in cords or trabeculae with some abortive follicles. See, whenever you're talking about an embryonal component anywhere in the pathology, either in ovary or something, you will find that there is this trabecular or cord formation, and abortive follicles is that they are just attempting to form the follicles but still have not formed. That's the reason abortive means just not born, something like that, or just ended. Okay, so the cytology shows little variations in cell and nuclear morphology. So atypical adenomas are like they have packed spindle cells with variation in size and morphology. Okay, then Hürthle cell adenoma, I told you Hürthle cells are the cells with abundant eosinophilic granular cytoplasm with vesicular nucleus, right? So this you see in Hashimoto's. Again, these type of cells, if those cells proliferate to form an adenoma, then that is a single nodule, then it is called as Hürthle cell adenoma. Papillary adenoma, very rarely seen, that is having a large papillae, and which is, it has to be differentiated from the papillary carcinoma encapsulated variant, wherein there is capsule formation clearly, but still you see the nuclear features of the papillary thyroid follicular cells being abnormal. Okay. So this is a follicular adenoma. You see that these cells, how these cells, how small the follicles are compared with, this is a normal thyroid gland. This is the well demarcated capsule that you are seeing, and you see that the capsule is intact and it's not breached. You don't see these kind of cells going inside here, and here you are seeing the normal thyroid, and this is the adenomatous picture. Okay. See, in the microscopy, you can't cut the whole. For example, I tell you an onion or an orange for the example of this, right? So you can't see the whole orange and put it on the microscope. So you cut a part of it wherein there is a nodule. For example, you are just cutting this part as a square, this part as a square, and then you see. Okay, so that's how it is. And this is another example. Intact capsule, you see the thyroid follicular cells which are different. And here you see the hyper picture of the adenomatous cells, wherein you see very less stroma, and then you see a lot of thyroid follicular cells which are arranged in microfollicles. So how it presents, it's a painless neck mass, usually with the pressure symptoms, radio uptake, cold nodule. Usually the functioning of the solitary nodule is less seen, that's why it's not hot. Mostly the hormone is secreted autonomously but depends on TSH. So anyways, it is the diagnosis of thyroid is largely dependent on FNAC and biopsy. Now coming to carcinoma of thyroid. So adenoma of thyroid is a solitary nodule present in the aether lobe of the gland or isthmus, having a well encapsulated picture grossly. It can be red tan, also have lot of degenerative changes like cystic change, hemorrhage, necrosis, fibrosis, calcification. But in the microscopy, you have types like macrofollicular, microfollicular, embryonal, then you're having papillary, or Hürthle cell. All these types are of the follicular adenoma, right? Or adenoma types means you can say all these types. So the thyroid carcinoma, common papillary adenocarcinoma associated with radiation exposure. The thyroid carcinoma, how is the percentage in the young? Usually papillary seed in adolescents, 20 years, okay, young 45 years, less than 45 years of age. The spread is by lymphomas, prognosis is excellent. Follicular, 20% of the whole thyroid carcinoma seen in middle age, blood vessel spread, it has a good prognosis. Anaplastic and medullary are a little rare carcinomas, usually in the elderly age group, with variable and poor prognosis. So 20 to 40 years radiation exposure is the predisposing factor. As you know, the thyroid carcinoma is more commonly seen in females. The papillary, we have the see, the term papillary means finger-like. Okay, there is this finger, there is a fibrovascular stroma here, and then you find the cells lining the finger. Okay, so that is about the papillary carcinoma. So these type of cells you see in the microscopy, and in the gross you can find some gray white structure protruding out. Okay, so this account the most of the thyroid carcinomas. The pathonomic is the papillary folds. Samoma bodies are the concentric calcifications that are formed, and orphan nucleus is a nucleus of the papillary carcinoma, which is the pathonomic of papillary carcinoma, that it has intranuclear vacuolations, and it is the very pathonomic of papillary carcinoma. If you are seeing that type of nucleus even in an encapsulated solitary nodule wherein you're finding the papillae and the nuclear features are abnormal, then you should think about it as the encapsulated papillary carcinoma variant. So exactly, it's not known. It can be by iodine, it can be by radiation or genetic mutation with red PTC gene fusion, which leads to the oncogenesis. In the macroscopy, you see that it can be varying from 2 to 3 centimeters. It can have a solid or cystic nodules, very sometimes firm and hard in consistency, but usually if you're suspecting the carcinoma and you're finding a cystic change, think of it as mostly by clinical diagnosis itself as a papillary carcinoma, because cystic change is very, very common in papillary carcinoma. So it's well circumscribed, and the cut section is pale to white, routine consistency due to fibrosis. It may infiltrate edges in parenchyma, calcification, and cystic change calcification. I told you it's pseudomatous concentric, right? Pseudomatous calcification also seen in meningiomas. Okay, so just remember that pseudomatous calcification is mostly seen in papillary carcinoma. Okay, so here is a picture. You are seeing that there are 2 nodules here involving the thyroid gland. This is the cut section of the thyroid. This is the normal thyroid. And you have this multiple papillae, gray-white structures that are arising. And here this hollow may be because of the cystic chain that has occurred here. Here also you see this gray-white area. This is also the papillary carcinoma. Under the microscopy, you see branching papillae with prominent fibrovascular core, and then it has uniform cells. Sometimes there may be anaplasia. It can be unifocal, like only single place it is involved, or multifocal. Okay, multifocal is due to the intrathyroidal spread or multifocal transformation from the genetic material itself in each cell. So the nuclei I told you are the pathonomic of the papillary carcinoma, has the ground glass appearance with fine dispersed chromatin that's called as orphan Annie eyes, eosinophilic intranuclear inclusions and invasion of the cytoplasm, and nuclear groove may be present. Nuclear groove means, imagine that you have a dove with you, like your mother asked you to do chapatis, you have a small dove. If you put your nail and just cross it like that, how it appears the same way, the the nuclear groove appears the same way. Okay. And eosinophilic intranuclear inclusion means, see, there is a nucleus, there is a cytoplasm. The cell is like this, and then there is a nucleus, and then the cytoplasm. The cytoplasm goes into the nucleus. So we think that there is some bubble-like thing which is being seen in the nucleus, but it is actually the cytoplasm which is going and pushing the nucleus. So it appears like that, you know, if you've seen the neck rings How they appear? So the nucleus appears like a ring, and then inside there will be a vacuum. So this is the eosinophilic intranuclear inclusion that you see. And then some of my bodies I told you, right? There can be sometimes follicular pattern of growth. So you have to see the nuclear features, not that in each and every papillary carcinoma you see those papillary kind of structures. So there can be the follicular pattern of growth which is maintained, but the nuclear features are the pathognomonic. Okay. So this is the typical FNAC where you see this papillary finger-like projections, the stalk, and here you see that these are the abnormal papillary cells, which are usually it has to be like follicle, like gland, like what you have seen in the last class. Okay, so here these are the, see this inclusion, this is a beautiful inclusion that you are seeing. So this is a nucleus, this is a cytoplasm. So this cytoplasm is actually coming inside, forming a bubble-like thing. Okay, this is the pseudo-inclusion. That means it is not true. It is just a cytoplasm. It is giving a visual effect that there is something inside it. So these type of cells, see this is the dispersed chromatin here. Okay, this is all the dispersed chromatin. Okay. So this is a cytoplasm, this is the cell, cytoplasm, the nucleus with intranuclear inclusion. And then here you see the orphan type of nucleus. Okay, the ground glass appearance, and this is the cell cytoplasm, and you see the dispersed chromatin. So this is the histopathology picture. That is a cytology, FNAC picture, what you have seen, this one and this one. And here you see this is the histopath picture wherein you are seeing, histopath is a biopsy picture, wherein you are seeing the multiple finger-like projections, and then there is a stalk. Okay, and you can see this nucleus which is demonstrating the dispersed chromatin. Okay. Here, this is a somamatous calcification. See, this is the ground glass appearance of the nucleus. This is a calcification. So, what are the variants? Encapsulated variant, I already told you, follicular variant where there are follicles and there are no papillary structures. Tall cell variant, that means it is having tall cells which are having intense eosinophilic cytoplasm, sometimes misdiagnosed as Hürthle cell tumor because of its intense eosinophilic nature. So it can have vascular and lymph node involvement to distance metastasis. In an old patient, it has poor prognosis. So FNAC findings, you see monolaid sheets, highly cellulose smear, papillae-like projections, and the most important is that the colloid, which is normally, once you do a thyroid FNAC for a normal patient, you know that there is a colloid tinge that is completely seen in the background. But here there is very scanty colloid, and if at all it is there, it is chewing gum like, imagine a chewing gum. So some of my bodies and then pseudoinclusions, nuclear trees, groove, empty nuclei, distinct nucleoli, that is the powdery chromatin having a ground glass appearance. Metaplastic changes in giant cells sometimes may be seen. So the clinical features, slow growing, cervical lymph node enlargement is seen in about 20% of papillary carcinoma cases. So cystic change and lymph node involvement with a mass, thick of papillary. Advanced cases with dysphagia and hoarseness, cough and voice because of the pressure symptoms that occur in the neck by the enlarging thyroid to the esophagus and the trachea. So the lymphatic spread I told you is common, and sometimes by blood it can pass to lung, liver and bone. Prognosis is good. Multifocal invasion, old patient without capsule with invasion and metastasis, the prognosis still can be poor. So it's better in younger female, small size, unicentric involvement with a well-defined capsule, well-differentiated nature, and no metastasis. Well-differentiated nature means once, for example, in the skin, the activity of the squamous epithelial cells is to produce keratin, right? So once you see this keratin pearls and all, that means that the proliferating squamous cells in the carcinoma are capable of maintaining its own function, that is of the squamous cell. So the well-differentiated squamous cell carcinoma means it is the formation of the keratin pearls. In the same way here, if it is recapitulating its own structure and morphology and function, then it is called as well differentiated. Once it is, we are not able to distinguish whether it's a thyroid cell, what cell, then it is fully differentiated. So coming to the next carcinoma, it is follicular carcinoma, second most type, 40 to 50 years. I told you while discussing about the iodine deficiency, Graves' involvement of follicular carcinoma, nodular goiter may precipitate it. So it is circumscribed, permeating the capsule, infiltrating the surrounding tissue, and fibrosis is central and foci of calcification can be there. See, all the degenerative changes can be present either in a benign nodule or a carcinomatous nodule. For papillary carcinoma, you have to keep in mind the cystic change, lymph node involvement, and the nuclear features. In the follicular carcinoma, you have to remember there is a capsule that is getting breached. That's all will give you the whole story about it. Okay, so if the nucleus is called as papillary carcinoma, then invasion of adjacent parenchyma above the capsule is for the follicular carcinoma. So what we have seen sometimes, there can be that embryonal part, like abortic follicles can be there. Whatever may be the histological type in the follicular carcinoma, the behavior is the same. Okay. So the clinical course, slowly enlarging painless nodule, mostly cold nodules, vascular invasion is common. So you can see that while you are seeing the microscopic picture, that's histopath, you can see that there is a breach in the capsule as well as the capsular invasion, that is called as capsular invasion. You can also see the vascular invasion. Prognosis depends on the size, capsular invasion, vascular invasion, and anaplasia in the lesion. So coming to the third one, carcinoma, that is medullary carcinoma. This is an interesting one because it is associated with multiple endocrine neoplasia. It is a neuroendocrine tumor arising from the C cells. So while we are discussing, I told you that there are these cells which produce the calcitonin, which are parafollicular cells, right? So they are secreting out serotonin, somatostatin, and VIP. Okay, that is vasoactive intestinal peptide. Two types are there where it can be a sporadic type or a familial type. Sporadic type occurs in adults, single lobe, and is aggressive. In familial type, it is usually associated with men, that is men to A, men to B. Both occur in young, they are aggressive. Unlike a sporadic type, it is multicentric. The red mutation is seen in men to A. Men is multiple endocrine neoplasia. Men 1 is the parathyroid pituitary adenoma, and remember that. So it's the same thing. Men 2 is associated with medullary carcinoma thyroid. So it is solitary, multiple in both lobes, areas of hemorrhage necrosis, firm pale granite, tan in color. So microscopically, you will see there are many spindle cells in a trabecular follicle. There is amyloid deposition, deposits of calcitonin that occur in the adjacent stroma. This can be demonstrated by using an IHC. So in papillary carcinoma, nuclear features, cystic change, lymph node, papillary structure, pseudoinclusion calcification are the features. Follicular carcinoma, capsular invasion, vascular invasion, are the features. And in medullary carcinoma, the spindle cells, amyloid, are the major features. Okay. So here we see that there is electron microscopy. Picture shows membrane-bound granules within cytoplasm, and there can be foci of C-cell hyperplasia. So we've known that there can be a sporadic nature that is associated with dysphagia, hoarseness. The paraneoplastic syndromes can occur. What is a paraneoplastic syndrome? The paraneoplastic syndrome is something that there is a carcinoma or neoplasia occurring at one tissue producing hormones or affecting the other tissues in some other way. Okay, that's a paraneoplastic syndrome. Okay, and in the familial, usually it is asymptomatic and discovered in screening of relatives. That is association with multiple endocrine neoplasia, and metastasis is via blood. So here we have this medullary carcinoma. This is a normal thyroid gland, and here you see that there is this fibrosis and numerous cells arranged in form of the embryonal look like, you know, the trabecular pattern, and you can see this amyloid-like structure. You can differentiate this neoplastic component from this normal thyroid component. And here you are seeing that there is this polarized microscopy which helps us to demonstrate the amyloid that is seen in the medullary carcinoma. Amyloid is seen usually in the stroma. These are the cells, and this part is the amyloid. The fourth one is anaplastic carcinoma. It is undifferentiated tumor. I've spoken about well-differentiated tumor. Well-differentiated means you know while you're looking at the tumor that this belongs to thyroid, this belongs to skin. In an undifferentiated tumor, you can't say anything like that. It is aggressive. It is less than 5% of the tumor, and many have a dementia and other tumor as a result of genetic changes that happen in P53-like genes. So what do you see is large pleomorphic giant cells, sarcomata, spindle cells, small anaplastic cells. See, when you see only this component of small anaplastic cell, it has to be differentiated from the lymphoma and the medullary carcinoma. So this large pleomorphic giant cells, sarcomata, foci of papillary follicular structures may be seen, suggests that they arise from these tumors. So anaplasia can occur as a higher degree in the other tumors, and once you are seeing a large anaplastic tumor and then you see a foci of a papillary structure or follicular structure, then you can think that initially it was this carcinoma and then it transformed into an undifferentiated tumor. So in papillary, you're seeing cystic change, lymph node, papillary structures, nuclear features like orphan nuclear, ground glass, intranuclear pseudoinclusions, all of that, subamatous calcification. Follicular carcinoma is see the compact follicles, and these follicles can cause a breach, and then there is a breach of the capsule, that's capsular invasion, vascular invasion. Medullary carcinoma, you're seeing trabecular spindle arrangement of the cells, and then you see amyloid deposition. That is a pathognomic of medullary carcinoma. In anaplastic carcinoma, you're seeing multiple giant cells, sarcomata spindle cells, that is, whatever spindle cells you are seeing, even that are pleomorphic. And then small anaplastic cells that have to be differentiated from the lymphoma and the medullary carcinoma. So here we see that there is rapidly enlarging mass, surrounding structures, and then compression is common. No treatment is available. As I told you, these undifferentiated carcinomas are very aggressive and death may occur in just 1 year. So this is the typical what you're seeing. See this cells. There is. Can you identify any thyroid follicle here? No. So absolutely. So you can't make it that if I don't tell you that the DOS is the thyroid, you can't see. You know, you see this very undifferentiated, very aggressive kind of cells here. Okay, prominent nucleoli. So that is about the thyroid disorders. I finished all of them. So you should be thorough with all the thyroid disorders, and there is the subsets like when you're talking about an encapsulated papillary variant or a tall cell variant or a columnar cell variant, there are some variants, but then if you're able to write those papillary features, then that would be more than enough. So keep in mind while you are looking at a carcinoma, you have to look at the gross, you have to look about have a detailed clinical history, because sometimes in the medullary carcinoma you have a familial association, and in papillary carcinoma there can be a radiation exposure. So detailed family history, detailed clinical history, have a FNAC, do a gross examination after thyroidectomy, then do a microscopic examination. Sometimes special stains are required for demonstrating amyloid under polarized microscope like in that of medullary carcinoma, right? Thank you so much for your listening.